it's an honor to be here, and congratulations to the award winners. I hope I can share some insights that will be useful. Dr. Ackerman, again, let me start off by thanking you for this great opportunity. I am so excited to be the CEO of Sinai Chicago. It is, like was said, the largest private safety net actually in the state of Illinois. And for those who don't understand exactly what a safety net means, it means that safety net hospitals that make up our system, we don't do the wallet biopsy. We take care of everyone who comes through our doors, and we don't find creative ways to shuffle them somewhere else because they don't have the ability to pay. That sounds like something so basic, but I will say that is a special feature. And so by doing that, we are able to serve anyone that needs us. Typically, safety nets are embedded in some of the poorest areas of the city. That is also the case for Sinai Chicago. We are located, our different hospitals are located on the west side and the southwest side of Chicago. The communities that we serve have, for all the indices that you look at, lowest home ownership, highest rates of chronic disease, lowest academic indices, high rates of unemployment, food deserts, et cetera. So as we think of that as the baseline in terms of the communities that we're operating in, it means that we also have the lowest rates of people actually being insured. And so that means a lot of the people who are getting care in their community are not able to pay. And so we frequently, actually annually, get the awards for the system, across the nation in terms, the award for the most charity benefit, the most community benefit. Last year alone, we gave over $50 million in charity care, in addition to all the other community benefits that we offered. So how can we afford to do that? Well, we actually can't. We actually can't. When other health systems talk about, having a rough year following COVID and having to dig into endowments, we don't have that kind of, quote, safety blanket or reserves to fall back on. And so even though we are private, I argue, and I argue frequently to my state legislators and state leaders, that I am a de facto government entity, because 70% of our patients have Medicaid, only about 20% Medicare, 1 to 3 with private insurance. So, PPOs and HMOs, I'm a patient, so we have a couple of us, but very limited private insurance. And then it's up to, 5, 6, 7% completely uninsured that forms our charity care. So it's a special calling to serve in that type of environment, because by almost design, we will not have all the resources that are actually necessary. And I have all these stories of docs who have worked in different settings, the well-resourced entities and hospital systems, and then either coming from Sinai or going the reverse traffic, and just seeing those stark differences. But still, we have the same responsibility. We have the same charge to give people what they need. So let me tell you a little bit about why I chose this role, because there were some, there were many, when you have job opportunities and you have to weigh out, what you want to do with yourself, you have to think about needs, and you have to think about service, and you have to think about impact. And thinking about the job that I came from as the director of public health, that was a time when, obviously the director of public health has so many roles, but because my tenure overlapped with COVID, I get like, oh, there's the COVID lady. Oh, there's there's the COVID doctor. But really thinking about, the public health system and all the things that we do, I remember first describing it to my kids and trying to explain, what the role entailed. And again, public health has always been that field that when things are smooth, you don't have to think about it at all. We liken it to plumbing. Nobody thinks about plumbing until there's a problem. Then you're very aware. Then you're very aware. But when the kids are going to go to the lake or a beach, sometimes there might be a sign like you can't enter today, and you're like, whoa, I came to go to the beach. Why can't I go in? But public health people have been monitoring the water to make sure that it's not too polluted so that people don't get sick. Chicago is a great restaurant city, and we love all the great eats around here, but we have to make sure that there are policies and procedures in place so that samples of all the food that's prepared are saved for the hopefully rare instance where someone or multiple people or full-on outbreak of people getting sick who all had this common history from the history taking of dining at the same place, and then being able to track the foods and do the testing. That's what public health does. I am 100%. I know how many people actually watched the Iowa LSU game earlier this week. Okay, yeah, you were one of the 12.5 million. So I am a proud Hooper mom. I have a big basketball star that actually we're trying to decide where she's going to play for college. And so like right now I'm in travel season, and every weekend, like this weekend I'm in Indianapolis, the next weekend I'm in Pittsburgh, the next one Bryan, Texas, and so sometimes my daughter will be like, oh, does the hotel have a pool? And so thinking about just the pool inspections and how every one of those pools, like, were they inspected? Like from the state, I know all of the people that were involved with pool inspections, they were like, we never go in public pools ever, and it was just because you don't know if people are following the regulations, if it's been recently inspected, did something happen after the last inspection? So there's just, not to scare you, summertime's coming, enjoy your pools. Enjoy your pool, summertime's coming. But just really thinking about the breadth of what all public health does. And I know I'm speaking to the choir, many of you know this, but sometimes I think, people are in their one piece of public health and don't realize the full breadth. So in addition to trying to promote healthy behaviors to reduce chronic illness, which involves educating, promoting, movement and activity, healthy choices. We want to avoid smoking. We want to push seatbelts. Let's remember that once upon a time, seatbelt, I grew up, I don't think that the cars had seatbelts, right? You had kids sitting in the back of the pickup truck, and it's really like just seeing that just in my lifetime. And I actually remember some of those debates. Well, the seatbelts will make me lose my life. I'm not going to wear a seatbelt, and you can't make me, and this is my personal freedom. And I just remember so many similarities to what we saw just a couple of years ago. So just really thinking about, what public health does, and also like the pushback that is part of it, because at its core, public health is socialist, right? It's thinking about the common good. And so the concept of rugged individualism doesn't align well with public health. right? It just doesn't align well. And so you have to think about what public health does and think about how it really is about a collective. And it's about thinking about what everyone needs and not just what the haves need or what those with money need or those in that zip code need, right? And so it really is a little bit hard. I think it's almost, I guess you can almost understand why there's such a struggle when some of these issues come up, because we have a little bit of a a chasm, if you will, in terms of how we should be approaching this. And that's why I think public health is not always as well regarded and as well supported and as well funded as it should be, because we have this idea that, do for yourself, pull yourself up, do what you need to do. And that really goes against public health principles. So thinking about other things that we do in public health, it's assessing maternal health and infant health. And that's so critical. When you think about maternal health and you think about the US having maternal mortality rates that are some of the lowest compared to other, quote, developed countries, despite all the dollars that are spent, that really says something, because maternal health is literally the bedrock of foundation. You're talking about youngish, right? Youngish childbearing women are relatively young, young women who are trying to do one of the most critical roles, bring forth that next generation. And if they are not able to do that safely, then you are talking about not just impaired ability to bring forth new people to replace ourselves, but also the starting point for that new life may be already pushed back behind the starting blocks because of adverse consequences associated with their delivery and entry into the world, being mothered by a mother that's not at her full capacity and capabilities because she has been adversely affected from the pregnancy process, and what that means for that new child to not have a mom at her 100%. So all of this is so significant. And so understanding that we have issues in our maternal health and infant health statistics is a very significant thing to take note of, and that public health is actively working on. Vaccination rates, of course, that's another critical piece where we thought measles was eradicated in the United States. I guess we're wrong. And then really thinking about, the advances in medical technology that we just completely take for granted and then turn away from because, I don't know, TikTok said you don't have to do that, or some debunked researcher has put it out there that the vaccine that has eradicated so many of the diseases that made 1 in 5 kids not make it to age 5 is now a problem that you shouldn't take. And so, I always talk about, we've seen, I'm an avid tennis player, and one of my, actually my captain's brother is, he is deaf, and he's deaf because he had measles as a child. And nobody really, like, I am a pediatrician. I've never seen a case of measles, right? I haven't, been upfront with these cases that have happened. I have not been the treating physician, but in all of my training and in all of my direct clinical work, I never had to see a case of measles. It was looking at it in the book and trying to understand what it would look like, so you could pass the board exams and, see it when they show the picture, on the exam so that you could recognize it. But the fact that they have the chance to come back because we have voluntarily turned away from vaccines is a sad state of affairs, but something that is really critical and crucial that public health is monitoring. Vaccine rates throughout the state. We flu surveillance, the number of people who are hospitalized, cancer stats for every single cancer, who's getting it, who is it killing, who is it more prevalent in, all the vital statistics, just, who was born and when, newborn screening, just there are at least for, and I know there are, 50 different state health departments, and they say if you've seen one health department, you've seen one health department. They're all a little different, but here at the Illinois State Health Department, we have literally over 230 different programs. I've listed 20 of them. We have 200 plus different programs that are working behind the scenes, trying to keep people well, trying to collect the data, trying to notice upticks or downticks in certain things. And then, of course, there was COVID, yeah. And in an instant, everyone was more in tune with public health, and everyone was the armchair epidemiologist, and everyone had a lot to say about vaccines and viruses. And so, it brought public health, to the forefront, which was good and bad, of course, but it became something that everyone was aware of. Public health wasn't behind the scenes anymore. In fact, it was right in front of you, in front of cameras, in your living rooms, on TV, almost every day. In an instant, people learned what congregate settings were and the risk that posed in infectious diseases. People learned what an essential worker was. And everyone got a crash course in underlying conditions, that diabetes or heart disease, hypertension, asthma, that those put you in a specific category that made you more vulnerable and made you more likely to have severe consequences of this new deadly virus. We tried to talk about the power of it was such an interesting time, right? It was, when first talking about it, like there was not enough information. And so really standing in front of reporters every day who are asking questions that just the answers weren't there yet was a challenge. But one question that always came is, when's the vaccine coming? When's the vaccine coming? When's the vaccine coming? And then somehow that morphed into, well, why do you think we would need to take the vaccine? And why is it safe? And what if it does this? And it was very amazing transformation. The power of social media, yay. Okay, but again, so many people in vulnerable populations were appropriately anxious and worried about the impacts of what this virus could do. So at that time, COVID-19 did shine a bright light on inequities in healthcare. And, it wasn't that, oh, all of a sudden some of these inequities just popped up. Oh my gosh, what a shame. Like they had existed long before any pandemic, hit. But the fact that everyone was talking about it, and that this new virus really not just exposed these inequities, but also leveled very, very severe consequences and impacts on some of the same communities that were already suffering from disproportionate levels of disease and suffering and trauma. And then, disparities and health equity and social determinants of health really became, new big buzzwords as well. But those who were working and have been working in public health and population health and serving communities in need, this was not anything new. This was oh, look who's joined the party now. And so for those of us that have been on the front lines of care in public health, population health, who've been working in health departments, just local health departments, just a buzz. And you've noticed from my style, I jump and dance, so bear with me. But local health departments, so we have our state health departments, and then we have local health departments. How many local health departments do we have in the state of Illinois? Nice try. No? Yeah. We have 97. So how many counties do we have? Look at these Northerners. You guys don't know anything about your state. You are just up here in your little Northern Illinois bubble, not knowing anything below. Well, that was me too, right? There are 102 counties in Illinois. And so almost every county has a health department. Some are much smaller and they share one. So we have 97 local health departments. Across the country, there are over 3,500 local health departments. Of course, we have their state health department, and then we have our federal health department, also known as the CDC, right? And so all of this interplay are important group of workers that are really always underfunded, always underappreciated, but the weight that they're carrying is very mighty. So that's the space that I was living in, and then had the opportunity to join the safety net. And it was just this wonderful idea where, yes, you can see everything that's happening at the micro level, at the state level. Given all of that, is there something that we can do? Can we take some energy and take the passion and see what can actually be done at that local level in the communities that need it most, for the 1.5 million people that the safety net health system serves? So that was the draw and the pull that led me there, and really just taking in everything. I always say that we're a sum of all of our parts, and all of our parts include all of our past experiences, all of our past educations, all of our life. So I'm a physician, but I'm also a mom. I'm also a woman of color. So as a Black mom and the mother of a son, I'm a mother of a Black boy, which has its own set of things. So there's all these identifiers and layers. I'm a daughter of immigrants. That brings a set of experiences that comes in. I come from South Central Los Angeles, which looks very much like Englewood or the West Side of Chicago. So we bring all those pieces in, hopefully using all of those experiences to be able to better relate to the situations that come in front of us. And so using that lens, our phrase at Sinai is now more than medicine, it's personal. And it is so personal for me because of my story and how much I can relate to the people who surround the institutions that I'm so proud to lead. And because I understand what it means to, only get, dental care when there was some kind of, free dental screening that was offered at a park for a local health fair. And I understand I did not even know that the cheese in the cardboard box, I didn't even know at the time that meant that I was, on public aid. I'm really glad that I was never, put into that box to think of it. And, and so when people would talk about it, and I would say, oh yeah, we have that. And they're like, oh, so you were on, I was like, no, I wasn't. But just understanding that, there are different experiences, and there's a group of people who have not had all of the opportunities to live their best life, and being able to have an opportunity to have a small impact, hopefully change, at least bend the arc, was something that's very gratifying. I know a lot of people said, oh my goodness, are you kidding? You've already been in the fire. Don't do that. And I said, I think to whom much is given, much is expected. And I also believe that the important work is never easy, so we can't shy away from the hard stuff. So I think public health people are in that same bucket, because really trying to communicate with people, trying to reverse trends, trying to get people, who don't want to use condoms, who don't want to get off their derrieres and walk around, and get them to be more active, that don't want to put down their cigarette. Like, that is hard work. Behavior change is some of the hardest thing that we can ever do. And yet that's actually fundamental to public health as well. So this is, very important, very challenging work, and God bless us all. But it is, and it's, the quote from Martin Luther King that I have like on the tagline for all of my emails is, once he says, injustice anywhere is a threat to justice everywhere. I think that's true, but I'm so sorry, like I am managing between my phone and my written notes. Hold on. Okay, I will get to that part. So public health, when done right, is inextricably linked to health equity, and it should erase health disparities. Some really poignant examples that I think about from the pandemic were trying to make with the knowledge that there are some communities that are more vulnerable than others, you have to think about what you can do to bolster that group. And so again, I know we all know this, but equality and equity are not the same, right? And to those who are further behind the starting blocks, we need to do more for those to get them, up to the starting blocks. And so when people say, well, that's not fair, why are you doing that? It's like, because you're already 50 steps ahead, and we are trying to narrow that gap. And sometimes that is something that's still quite hard for people to accept. So when we think about, when we did have the vaccine, and for the people who were like, oh yeah, vaccines are a good thing, I should get one, we had to look throughout the state to figure out, because we had our pharmacy partners. And so looking throughout the state where these pharmacies were, it is a fact that the pharmacies are less densely located in the poorer communities. So again, the poorer communities that have the most chronic disease and the worst outcomes have the least access to the vaccines that could help save their life, right? So really at the state, trying to get a handle on that, we were trying to fill in the gaps, right? Trying to find the locations that would be able to be, central to many of the people that were most in need, to try to make up for those imbalances. And so putting them, in the poorest communities was a priority, to try to see if we could stave off these really disparate outcomes in how the virus was treating people. I remember traveling to a place downstate where there was a deserted, a mini mall that was no more. There were no buildings, there was no businesses that were still there. And so this was a big open space where, great, let's use this. We have this space, we can have a vaccine station here. And so we went down to go see that vaccine station, and then we were there was like nobody there. Like, it was like, gosh, like, we know that there's a need. We know there are not a lot of other options. Like, how can there be so few people at this vaccine? I mean, literally, like, the National Guard and all the vendors were just twiddling their thumbs with hardly anybody coming through. And so then, talk to the local health department and talk to the community members to try to figure out, like, is it just no one wants to get this vaccine? Like, how come, we've invested all these resources and no one's here? Like, do you see where this is located? I said, yeah, it's a big open space. They're like, but how far apart is it from the main road? And I was like, yeah. You have to, drive in and get to, the back of this place. They're like, yeah, but that is the problem. There's no way for people who don't have a car to get here. Okay. So then we worked with the city to redo the bus lines temporarily to come into that little mini mall and come have a stop so that people don't have to get off blocks away, because people probably got off the bus and saw that it's not close enough and then left. And so understanding like these details, like being equitable is hard. Being equitable takes intention. Being equitable takes perseverance. And yes, it costs more resources. But if we're really serious about getting narrow disparities, that's what you have to do. Every single week, we would put up, for the governor, the numbers of people. We were tracking every single shot that was put in an arm. And whose arm it went into, trying to make sure that we were not seeing that continued disparity and that we were actively working. And so when we saw that, oh, wait a second, whites are at this rate, but it's 20% lower for Blacks and Latinos, that means we had to redouble our efforts. We identified community ambassadors. And so through the 102 counties of Illinois, we identified, moms and teachers, coaches, religious leaders who would agree to share IDPH like pictograms and, social media posts, and would reshare it to kind of rally the people or spark conversation. Maybe someone, because we definitely had counties where when our public health workers were going, we were literally going door to door in places that had the lowest vaccination rates. And we would go door to door, and we had people, guns pulled on them, dogs put out on them. And so it was really like we had to come back to the education because people weren't always ready to take it. And so trying to find those trusted messengers in the community was a key strategy. It's a key strategy for health. People don't care what you know until they know that you care, right? And so when you just come as Johnny come lately and say, hey, I've got this great thing to shoot up in your arm, like who are you and why would I let you do that to me, right? As opposed to like if you have a trusted, family physician, or if you have a trusted religious leader who is talking about this and sharing some of the information that maybe they have garnered, then there might be an opportunity for someone to soften their ears, soften their heart, and hear what you have to say. So we were trying to do that with these community health ambassadors. I'll tell you, it was hard to find some of them in some of the counties, but we found, by the end of it, we had over 1,500 ambassadors who were sharing and resharing all of this information, trying to stimulate conversation. And then, if we needed to find, if we could assemble a group, then we would either have a Zoom to talk about, answer people's questions, really just hear people, understand the hesitation if that was the case, and try to address it. People have agency and they will do what they want, but you want to have people empowered with the facts. And because there was so much, misinformation and disinformation that was out there, it was hard for people who didn't have, a lot of medical background. Health literacy is poor just in general. And, a lot of times docs aren't the best at translating medicalese into English. And so really being able to meet people where they're at and try to share the information, ask the questions. Some people will be, early adopters, and some people will be late adopters. I'm sure like the same thing with the people who are the first ones standing out in line to get their new iPhone versus the people who are like, no, I'm good with mine for a while, and I don't need to change it right away. So that's how it is with anything that you're trying to get someone to come on board. But whether we're talking about viruses or water or chronic diseases, food deserts, violence, we do consistently see these disparities, and for too long, too many have been on the outside looking in when it comes to healthcare, and that leads to poorer quality of life. So this fight is not just equity, it's justice. We need to make sure that every human gets the care that they need, and that healthcare is not a privilege, but a right. That's really the fight that we're in, and I think there's so many things that tell us that that's not really true. I don't know if everyone believes it. I think when you think about healthcare being a right, then there are things that you have to put into action, and not just say it. There are clear actions that need to go behind that sentiment. It's not just words. We have to invest into ensuring that there is true equity and real justice. We have to make sure that your zip code doesn't mean more for your health outcomes than your genetic code. We have to make sure that everyone has their best opportunity to live healthy and happy. Chicago has a history of conquering challenges. It starts with the Great Chicago Fire of 1871, and the city was completely rebuilt bigger and better. And it set the stage for many of the bold ideas that have shaped the city for those since 150 years. And so there has to be a mindset where we are setting the stage so that we can think about what does our city need to look like. And it's not something that just public health leaders can deal with. It requires legislators, it requires business, the civic community, it requires maybe the philanthropic community, it involves the community-based organizations, it involves the communities themselves. All of us need to work together to help us set the stage for this comeback that we need to make post the pandemic and the trials and tribulations of it. I think a door has been opened that has great and dramatic opportunity, and it's right here in front of us, and we need to do what we should be doing to make this place a place where every Chicagoan can be healthy and thrive. So that's our great challenge, and I think it's obviously possible. We need the will. Chicago is the country's third largest city, the third largest economy. It's bigger than many, many countries' economies. And we do have a remarkable history of business and civic leadership. And we have a tradition of incredible institutions, but we rank 66th amongst cities nationwide for healthcare access. So I'm looking at my time and seeing I'm way late. So let me speed this up, fast forward. Okay. Let's keep it going to the last couple of pages. So let me just get to like what we can do. So we need to work to support our new and growing families from the start. We need a heightened focus on innovative solutions during pregnancy, deliver, and postpartum care. We need to look at the importance of investment in the safety nets. The safety nets are unfortunately set up to fail. You can't ask anybody that works at Northwestern. You cannot run a hospital on 70% Medicaid, right? And so what do we need to do for hospitals that are in some of the most economically depressed communities where by definition will likely have less people with employer-based insurance, what do we do to those hospitals to make sure that they can give the care that's needed? And let's think about it. We talked about equity and not equality. For someone who has a higher rate of chronic disease, who has issues with transportation, where there are no grocery stores in the neighborhood, that patient needs more, not less than your Northwestern patient, right? And so we have to like reverse the concept of what is needed for the safety net. So legislatively, we need to think about a special designation for hospitals who are trying to do this work. You know, safety net hospital is more likely to have someone who is not English speaking. So whether it's needing, you know, translators or transportation or, you know, vouchers for Lyft, all of those things cost more, not less. And meanwhile, like, we don't get a pass in terms of, okay, you're a safety net, so you get to pay all of your employees half of market rate, right? Like, that doesn't work either. And so really all of the expenses are the same, if not more, because of the extra needs, and yet there's not the resources to cover it. So we need to look at this data on health disparities. We need to understand social determinants of health. We need to be involved with decision-making and policy development. We need to work very intently on communicating. Health communications and messaging is a critical piece. I just saw something that the Cook County Department of Public Health has put out where they have like a series of like commercials or little snippets, like cartoon snippets with characters, public health characters representing all different backgrounds who are talking about some of these basics of public health. You know, we need to be in a position to educate and train the next generation of healthcare professionals, public health leaders, and researchers. And we need to incorporate all of those public health principles into everyone's curricula and training programs to prepare a new generation of providers who will actively advance health equity and justice. And so we need to bring all of this expertise together and advocate for the policies that are necessary. We need to be educating people. We need to make the case at the local level, the state level, the federal level. We need to improve our flawed system, our tiered system of insurance, that you're poor, you get this insurance, Medicaid, and that means you can't get this, this, and this. And if you have, you know, the PPO or concierge medicine, then the sky's the limit. We need leadership and expertise to serve as advocates for evidence-based approaches and best practices. And we need to spend less time we need to spend time researching, but once we've identified the problem, we need to spend less time just massaging and just highlighting the problem and actually work on the solutions and really focus on those solutions and then study those solutions to reiterate if there's more changes that need to be made. One of my mentors is Dr. Helene Gale, and she said that health equity is the defining issue of our time. It demands our attention, our resources, and our commitment to justice. We're facing a moral imperative where the stakes are truly severe. It's life and death, literally. So this is something that demands our minds and our hearts, and our moment is at hand. It's not about buzzwords, it's about action. And may God help us if we cannot summon the will to seize it. Thank you.
We're going to open it up for a few minutes, just for a couple of questions. We have a couple of microphones to pass around. Sorry.
No, I forgot. I forgot.
Questions for Dr. Ezike? Yep, we got one right here.
Thank you. Thank you so much. As always, you're brilliant. I was really interested when you talked about the 1,500, I wrote it down, public health ambassadors across the state of Illinois. Now that COVID is, I won't say completely in the rearview mirror, but somewhat, is there any effort to deploy those individuals to address things like chronic health disease and other sorts of public health initiatives?
Oh, I haven't been there in a couple of years now, but, I think the plan definitely was to keep those, I mean, because those people weren't actually going out. It was just reposting stuff and, trying to stimulate that conversation. And so the plan was to continue that, just to have people, because, if you look at the IDPH website, like how many, like it got the most followers in COVID, but it was never like, a top destination for people. And so just having other people try to send out those posts was a way to like increase our reach, spread out those tentacles. And so I'm assuming that those people are still being asked to share. I know, like pandemic goes down, like some of the excitement or the impetus to continue goes down too, but at least you have a set of people that were engaged once upon a time, and hopefully they can stay engaged.
Another question in the middle. Janet Shao.
I'm with the AMA, we work on hypertension, and I think that hypertension is stable. Of course, we have hypertension, and we have medicines for that, and that's good, so let's move on. But when we're looking at those cardiometabolic issues, these are really impacting community families, certainly the Sinai Institute. So what can we do for these diseases that are chronic, but are, I think the politicians are jaundiced to say, that we deal with that, that's okay. We need to look at these more big things. And I'm going to say like opioid deaths, which I don't want to denigrate anybody who's working on that. But anytime we have what is sometimes often seen as a condition we're all going to get if we're aging, it's a condition we're going to get if we don't eat.
Yeah. No, I mean, I guess, no, that's right. I mean, it's called the silent killer for a reason, right? Because people don't even recognize the significance and the importance. I mean, there's so many ways to approach that. Obviously, we want to, putting on our public health, move more upstream because it is preventable. It's largely preventable. It's about diet. It's about activity, which again, like all of this stuff is so interconnected. It's really hard to tell people. I remember working on the west side at the Austin clinic, and it was, like we just need to get, maybe 10 or 15 minutes, like let's walk. Yesterday, I think was National Walking Day. And people were like, Doc, what are you talking about? Like, it's not safe to walk, And so that kind of thing. So like, it's all tied to having safe spaces, which means what are we doing for the community violence? Like community violence is actually tied to chronic disease, because if you don't have a safe community to be active in, then you're sedentary staying in your home, right? If we don't deal with how we, give resources to educate people, and we say that your public school is going to be based on, homeowners' taxes, then you're saying that people, and our communities don't have as much home ownership, then you're going to have these underfunded schools where people come out not even being able to read, and then end up in the jobs that don't have insurance, right? That don't have employer-based insurance. And then this cycle keeps continuing. So there's so many levels to it. But of course, hypertension, once you have it, has to be dealt with, because hypertension here is, okay, you have hypertension, but then it goes on to like chronic kidney disease. And what does it mean when you go from chronic kidney disease to being on dialysis? What kind of quality of life when you have to go to a dialysis center 3 times, a week for 3 or 4 hours? Most of those people are not able to work. You're not able to be gainfully employed. And what does that mean for your family that you're responsible for? Because now you had hypertension that progressed to this, and now your family is, at the whim of a disability check, right? So all of this is so intricately connected and complex, and we need to try to attack it at all these different levels at the same time.
We have time for one more question. There's one in the back there. Oh, do you see?
Dr. Ezike. My name is Cecilia Torres. I'm with UNA Chicago. We promote the mission of the United Nations, and as a policy advocate for child care and welfare and health in general, I really commend you for the labor the daily words of hope that you provided to all of us during COVID. It was such a treacherous time, and I appreciate the interpretation in Spanish that you provided for my parents that saved me the interpretation. Thank you so much. You mentioned behavioral change is a fundamental to public health. In light of the frustration with the sometimes resistance to that behavioral change, how did you personally cope with the frustrations? Because it was very evident in your expression, your facial expression, and your voice, because we were living such times of despair and uncertainty. How did you manage to cope? What are some of the things that you did? As advocates, we go through the frustration daily. So I want to know from you firsthand, how can we better help ourselves so we can help others?
No, honestly, like I was just like privately saying like, you got through a speech where you talked about COVID and you didn't cry. And I was like, oh, I'm doing good. I'm doing better. I'm overcoming the trauma. These psychologists are really helping. And then you, like, so, okay, so I'm still good. I just got 2 minutes, so I'm gonna hold it together. No, it was hard. It's hard, and I'm still facing, I am still enduring. My family suffered a lot. In school, like they were told like it's because of you and your mom that we can't do this, so they were being bullied, and we got, threatening packages, people coming to the door, like it was real, right? Like state police escorting me around, like it wasn't fun, like really murderous death threats. It was hard. I mean, it was hard, and still you have to go up there every day, right, and maintain your composure. I credit all of that to literally to my Lord and Savior. I know it was just Easter weekend, whatever, but I'm just saying, like, if I didn't have like a very deep faith, I couldn't have gotten through. And I really felt like I was called for such a time as this. And so when everyone was like, you don't need this, leave, I really felt the need to stay in place because I thought that I was being used to do something greater than myself. And so your kind comments to start saying that I did make a difference is the reason why I was able to stick it through.
Dr. Ezike, thank you for your brave service to the state and the people of the state. As a token of our appreciation as distinguished speaker. Thank you. And that concludes our schedule today for the 2024 IFAM Population Health Forum. Thank you all so much for participating. Thank you for being part of the entire day. It's only a success if people come and engage and network and if things happen afterwards. So thank you. Enjoy the rest of your day, the rest of your week.